Is Victoria Campbell. Victoria is a renal physician from the Sunshine Coast, in Queensland, and she's also the clinical lead for Queensland's implementation of digital vital sign recording. Thank you.
Thanks very much for the opportunity. I'm also an intensivist up on the Sunshine Coast, so I can sort of straddle the acute care, critical care component and the ward component of these systems, which I think is a great advantage for me. Okay, so the first thing I'd like to do is say what an incredible honor it is to be speaking in front of a room full of the greats, the global greats of rapid response systems, and people who recognized not too many years ago that we had a safety problem and became committed to solving that problem and are saving lives. And it also gives people like me the opportunity to build on those processes and the inroads that have been made into governance and executive to progress these things. Sorry, I'm short. But the reason I'm here to give the talk is to say what are the challenges to the current paradigm of MET systems and MET utilization. What we've realized over time is that not all the patients that trigger a MET alert need to be rescued. Some of them have some hypotension, not because they're deteriorating, but because they need their antihypertensives adjusted. Some of them are in need of goals of care planning and a peaceful death. We've also identified, and Josh, thanks for a nice segue into this, that the earlier the better. And in fact, once we're reaching MET thresholds, we probably could have picked that up earlier. And preventing deterioration is going to be better than recognizing and responding to it. We've already heard from Sophie about de-skilling, which we all recognize as a problem. And we are also all watching our MET doses rise over time without a ceiling. So how did we get here? Well, as I said, clinicians recognized that we had a problem that needed a safety net. And we had a rapid, widespread implementation, certainly within Australia, rightfully so, and across the globe, of rapid response systems that, due to the inability to generate evidence quickly, were developed by clinical expertise and, I'm having trouble seeing that, and opinion. What we've done is subsequently begun to accrue retrospective evidence that we can bring out and use to modify these systems over time. And an example of this evidence is just looking at some Queensland data. So Queensland has 2 hospitals that have absolute mandatory MET calling if an alert is fired due to clinical incidents that occurred. And what that means is that for patients who trigger a MET call, we have a more than 90% compliance with that actually generating a call. That means that we can collect some pretty clean data on what these calls are doing for us. And what we found is that all MET calls, of all adult MET calls, only 3.9% of them required critical care input or transfer. 25 to 30% of the calls for isolated hypotension or asymptomatic hypotension, and I'm sure that other places have seen similar numbers. And less than 1% of those patients actually required anything more than fluid or ward-level care. This equates to 1 in 20 patients on the ward at any one time, and my renal registrars have 20 patients on their list, so that's 1 of their patients at any one time, and therefore should really be in the scope of their practice on the ward. We also have the potential for causing harm, and I believe that we are at times getting the wrong expertise to the wrong patient at the wrong time. We have patients who generate multiple MET calls, and just because of logistics and having to leave the ICU, they get moved into ICU, and I've seen patients who've ended up having unnecessary ICU procedures as a result of that transfer. Patients in my renal clinic, and I don't have that many, have come and reported to me experiences of fear and anxiety when a big team turned up at their bedside. One in particular patient, although he was reassured repeatedly by the team that he was fine, didn't believe it and got left. It's a great way to bring their blood pressure up, by the way, for these hypotensive people, and their heart rate. So that's a potential issue as well. It also, as we know as intensivists, take our critical care expertise away from our critical care patients to see patients who are having cups of tea with hypotension on the ward. And it drives the modification and alteration of calling criteria thresholds on our charts. We've identified in Queensland that this occurs in 10% of our patients. It reintroduces human error into the mix, and it's being identified as one of the increasing causes of failed escalation in our hospitals. So what can we do about it? And this is the gist of the talk. Basically, we can use, with a lot of hospitals around the world now developing digital platforms and large digital data repositories, we can use this information to optimize and develop some of the research around those thresholds and MET tools that we're using. So I'm going to talk about that. I'm also going to talk about, and what that can do for the afferent limb. I'm also going to talk about what the digital platform offers as opportunities for our efferent limb, early recognition, and deterioration prevention. I have to disclose, too, at this point, that I am from a multi-track and trigger digital hospital, one of the 13 digital hospitals now in Queensland. So there is a digital flavour to this, and some of the benefits I'll talk about will not necessarily translate into the paper world. So the intent of our afferent limb, as we all know, and I know I'm preaching to the converted, is that we want to facilitate for the ward staff recognition and guide escalation to the appropriate expertise. These tools are not for intensive care patients. These tools are for the ward patients and the ward staff. As a result of that, and they're very busy, these alerts need to be meaningful. So we don't want them to be so sensitive that they're firing all the time and they develop alert fatigue. And we also need them to be specific so that if the alert comes up and says there's a problem, then they know that there is a problem. Obviously, again, I reiterate what everyone else has said at this meeting, and it does not replace clinical worry. That is the best indicator, and nurse worried has been proven to be the best indicator of patient deterioration. So, as all of our hospitals in Australia, around the world, as there's increasing hospitals around the world that are going into digital platforms, we are beginning to develop in Australia our own data repository. But for now, it's not that easy for us to access that information to get what we want. So thank you, Malcolm, very much for putting us in touch with the University of Chicago team after Malcolm published the paper in 2017 to allow us to look a little bit deeper about the early warning tools that we're using in Australia. And one of the biggest differences is, for us, first of all, is NEWS is used in the UK, which is a purely scoring tool. Between the Flags is used here, which is a single track and trigger tool. And what a lot of Australian and New Zealand sites are using now is a hybrid, a combination tool of a scoring multi-track and trigger with absolute MET thresholds as well to capitalise on both of those safety opportunities. Before I talk about the results, let me just mention how efficient it is to work with big data. So from the moment that we had everything signed off to allow the University of Chicago to analyze our data on their database, our tools on their database, we had our results within 4 weeks and at a fraction of the cost of what it would have been if we had been doing this manually or in paper charts. We were able to access more than 220,000 encounters or admissions and 5 million completed vital sign sets that included oxygen quantification. So that is, to have that quickly was absolutely awesome. There's a lot more detail to the study than I'm going to be able to present in the next whatever I've got left. So just to say that this paper hopefully will be published soon, and to say also that probably it will be sent to people in this room to review. So please be kind. What we did is we compared eCart, which is the Dana Edelson's advanced digital algorithm tool that includes not only vital signs, but pathology and some demographic data as well. We also looked at NEWS, which is a purely vital signs scoring tool. We looked at QADS, which is a combination vital signs scoring single track and trigger algorithm. And similar to what we've seen from New Zealand and what's being used in Canberra with Imogen with Muse. And Between the Flags, which is a vital signs single trigger algorithm. And the results that we found were not dissimilar to the results that are being published over the last couple of years around the world that's looking at the distinctions between these tools. And that is that very clearly the digital algorithm is going to be the way of the future for digital hospitals. The scoring tools then for predictive accuracy came after that, and Between the Flags was not as accurate as the scoring tools. So how does this translate? Because this is a talk about MET utilisation, and I need to distinguish that from patient outcomes because they're two different things, to Met utilisation. So when you looked at this data, in fact, not surprisingly, it translated pretty cleanly across, and that is that if you have an advanced digital algorithm, that you will have less Met alerts. So 15% of the admissions fired Met alerts with the digital system. Now, keep in mind, this is US data. There are differences. I won't go into details. The news and QAds, the two scoring tools, were similar in the percentage of encounters that generated a Met alert, and between the flags generated significantly more Met alerts in that validation. The other great thing about digital data is that we can actually use it to answer some of those questions that have been contentious amongst subject matter experts. So in Queensland, we had a subject matter expert workshop a couple of years ago. We've all talked about in this meeting how standardization is great, and we wanted to standardize our Met thresholds throughout the state. And there were two main things that came up that generated quite a bit of discussion. The first one was the low systolic blood pressure Met threshold. Now, obviously, this doesn't apply to ECART and to news because they don't have Met thresholds. They just have the scoring. With systolic blood pressure, and from the data that I've shown you from Queensland, it seemed that low systolic blood pressure triggers were low bang for buck, right? So we wanted to have a look at what would happen if we changed that threshold. Respiratory rate was the opposite. Respiratory rate, we know, is a great indicator, if measured properly, of deteriorating patients, and is a high specificity, high reliability. And despite that, there were two stark differences around Australia within these tools. There was a cutoff of greater than 30 or a cutoff of greater than 35. So we wanted to do a head-to-head of both of these and see what we found. Interestingly, the first thing we noticed is that it didn't matter how we moved these thresholds around. Our predictive accuracy was the same in these tools. So moving the Met thresholds around in these combination multi-track and trigger tools does not seem to make a difference to their predictive accuracy. What really seems to make a difference is that jump up to the digital algorithm. So it's not about moving them around, it's about adding parameters into the algorithm. The other thing that was really interesting is that it didn't matter where the respiratory rate didn't affect sensitivity, specificity, time to event, or anything. So there is no indication in a combination multi-track and trigger tool to have the respiratory rate set at 30. There was a big difference, though, in low blood pressure, low systolic blood pressure. And what we found was that statistically, even just between the QAds with dropping the blood pressure from 90 to 80, we could reduce the number of patients with a Met alert by more than 40%. This is statistically, keep in mind. Compared to between the flags, there was a reduction of greater than 60% of Met alerts in the system. But we know that there's things that the big data can't tell us. This is a statistical evaluation, but what happens in reality? We know that a lot of these Met alerts will not translate into Met calls. We know that we have altered calling criteria, which this data did not account for. We have patients who are not for resus who won't get alerts. We have barriers that we've talked about to escalation. It's one of our biggest problems. But we also know that we have nurse worried, so some of the calls wouldn't have been captured. The other thing is that when talking about not having an ICU response or a critical care response to someone with hypotension is what a second set of eyes, and particularly a second set of critical care eyes, might have added to early diagnosis and early intervention. The only way to establish that is through implementation. So Toowoomba Hospital, Adam Visser, I don't know if you're here, but thank you, Adam. Toowoomba Hospital, based on this and some of their own data, their data contributed to the Queensland data I mentioned earlier, did a quality improvement project, a 3-month trial of the QADS form with that threshold changed 80 to 90, where a score of 4 generated a medical officer review for a score of, for that threshold. Important to note that if they were, other organ involvement was occurring and they scored an 8, it would be a Met. So we weren't, it was really just for isolated hypotension. And what they found was a 25% reduction in Met calls, not as much as they expected, but still significant. They increased their nurse worried calling, which is good. There were no adverse outcomes, and they looked at end organ insults like acute kidney injury and acute coronary syndrome. There was no increase in that. As I said, if it was impacting on mentation, which scores a 4, would have been an automatic Met call. Only 4 out of 169 patients with a blood pressure in that range over the 3 months required an intervention more than fluid. They were reviewed, and there were no clinical incidents of concern. Less than 1% required critical care input or transfer, and it was fed back to me from someone who works on their wards that they had better flow through ED because the medical registrar was now not being called out to met calls. We are now trialling the new threshold QADS form in 8 of our sites. Look forward to the results and hope to implement that into the digital space, all being well. If you really want to know, though, along with Josh's presentation, about how we can reduce our MET utilization, it's stopping patients from getting there in the first place. We need to facilitate a ward-level response, and there's been an entire section of today's meeting dedicated to a non-critical care response to deteriorating patients. But our ward staff, our ward registrar has got 30 patients scattered around the hospital that they will see once a day, being looked after by a nurse with a 1:4 or 1:6 ratio. We need to give them a way to have visibility of who is getting sick. This is where I think the scoring tools come into their own strength. If you see the patient in the table, it is a gradual decline in their physical status, similar to what would be sepsis. We need to have an escalated visibility, a stratified visibility of this deterioration in order to have a stratified response to it, and the ability to recognize that those changes are happening over time. Just to show you, I think the ward medical officer alerts are just as important to get them right as the MET alerts, and our ward medical officer escalation alert frequency, again, the same pattern. Best with the digital system, the scoring systems, not quite as efficient, but with the Between the Flags tool, a yellow alert that is not stratifying will appear in 91% of admitted patients. We also can provide them with a real-time deteriorating patient dashboard, and this is the bit that's specific to the digital space. What we can show on that dashboard, and there's much better looking dashboards than this out there, but essentially, whoops. Oh no, it didn't work, okay. There we go. Essentially, we can show the ward staff how many sick patients they have, who they are, where they are, and they can drill down and see whether they're getting better or whether they're getting worse. So to prioritize their ward round first thing in the morning and handover, and this can be done at a nurse unit level or a medical unit level, they can have a look, decide who they're going to see first. They can do that whenever they do their handovers, and they can review. It can also be available for the MET teams, and so on. So where to from here? The first thing is that we are in our infancy from a digital perspective of what we can achieve in these systems. And we're all guilty of being keen to see our successful digital paper programs work in the digital space, but it's not exploiting the opportunity that we have. Our current MET paradigm is suboptimal. That's why I got asked to give this talk. We know that advanced algorithms in the digital space will be the future. I think in the meantime, we have enough evidence growing to support scoring tools. And I'd also like to say that I've had a fantastic opportunity to work with some great people in national collaboration with Malcolm and New South Wales and Victoria that has been facilitated by us being on digital platforms together. And I think I agree with what Ken and everyone else has said, that we need to see this at a national level moving forward and see collaboration in this area. Deteriorating adult patients don't vary that much in their physiology across the country. Thank you.
Thank you, Victoria. I might just get Josh and Stephanie and Ken to come up. Victoria mentioned